Hi, everyone. Welcome to our Addressing the Root, Dismantling Systemic Barriers to Oral Health Equity webinar. My name is Ruqayya Ahmad. My pronouns are she, her, hers, and I'm live here from Tongvaland or Los Angeles. I'm a policy manager at the California Pan-Ethnic Health Network, also known as CPEN, and I'm really excited for you all to join our webinar today. We have our equity core group here today, who will be discussing the recommendations in our recently published Addressing the Root report. And we will drop a link in the chat for that report shortly. Before we start, I encourage you all to introduce yourselves in the chat. I want to know where everyone is here from. Tell us your name, your pronouns, organization, location, and let us know what your favorite fall themed food is. I dressed in a fall theme today as well, so I'm really dreaming of pumpkin pie today. I get it every year from Costco and it never disappoints. And welcome to those who are still joining. We're really glad that you could join us today. I think, so for any event, we have to do some housekeeping before we actually begin. So Vincent, if we could go to the next slide, thank you. So if you're new to Zoom webinar, this slide has a photo with a breakdown of some of the features that we have available. Firstly, this webinar is being recorded and closed captions are available. So to access the closed captions, you can click CC Live Transcript at the bottom of the screen and then click Show Subtitle. You can also click View Transcript to see a transcript of the webinar. If you have any questions throughout the webinar, please use the Q&A function. You can click the Q&A button with the speech bubble at the bottom of the screen and type in your question, and we'll do our best to answer as many as we can at the end. And then I also encourage you to use the chat throughout the event, talk to one another, drop some relevant resources, news articles, connect with one another in the chat. And before we get into the actual report, I want to hand it over to my colleague Carolina, who is the Senior Policy Director at CPEN and supervised this work in our report, to start us off.
Hi, everybody. Great to see folks on the call. Thank you so much for joining virtually. My favorite fall weather food, I think it's a sweet potato pecan pie. It's a Paul Prudhoe recipe. If anyone is familiar with him, he's considered a New Orleans god, if you will, in food. And so I'm Carolina Valle. I'm the policy director here at CPEN. We are a statewide multicultural health policy organization that works to eliminate racial disparities in health. The purpose of today's webinar is for you to hear about some findings from our co-authored report, Addressing the Root: Systemic Barriers to Oral Health. There's tons and tons of convincing data that shows and really proves that people of color are not accessing services at the same rate as their white counterparts. And you can read our report and you'll hear a little bit about that data as well. But this report isn't just about that data. It's also about the role of systemic racism in healthcare and in health policy. Just a few examples that I know many of you could speak to, and there are plenty more. The state here in California has changed the scope of Medicaid adult dental benefits 3 times in the last decade alone, which we know has caused just incredible confusion in the program and resulted in providers leaving the program as well. And this has not only caused confusion for adults, but also for children and families as well. We still don't have, a comprehensive dental benefit in Medicare Part B. And we also continue to hear news stories such as, the lead contaminated water influenced Michigan. And so when we hear about stories like that, coupled with the systemic racism that people experience in their own lives, it's very hard to assure people that services and that their water is safe, right? But this report is not just about the nature of the beast, if you will. It's also about what can be done to really build an oral health system that is focused on public health, not private profit. So you're going to hear directly from some really amazing organizations representing different cultural communities and parts of the state on what really needs to be done in California and nationally to ensure that we have a racially just oral health system for people of color. Many of you could be up here today as a panelist speaking to these issues. And I want to acknowledge the amazing work that many of you have also done and continue to do to ensure that people of color have good and just oral health care. Just today, we learned some big news about the expansion of dental care and Medicare coverage for individuals with complex medical conditions, recognizing that it is not the comprehensive coverage many of you continue to seek. So that's a great win. Just this summer, we finally saw an expansion in Medi-Cal dental coverage to include custom crowns. And I know many of you on this call today are continuing to work on the ground to implement local oral health programming and public education as well for your communities. So a huge thank you to all of you for your work and your service. And thank you so much for joining today. We only have an hour together today, but the authors of this report who you're going to be hearing from are lifelong advocates, service providers, and champions of racial equity and oral health. So please do reach out to any of us, Ruqayya, myself, any of the CPEN staff, if you want to get connected and talk more. So on that note, I will pass the mic forward.
Thanks, Carolina, for that introduction and really kind of setting the stage and providing the context for the oral health space in California. If we could go to the next slide, please. Thank you. So we can't talk about health equity or oral health equity without first talking about structural racism. The historical roots of US racism, as everyone knows, began with the enslavement of Africans who were stolen from their homes to be used as stolen labor to extract wealth from a stolen land. And this racism was then perpetuated and further woven into US society through segregation and Jim Crow laws, through redlining, and now through mass incarceration. And so structural racism is really the intentional way that resources and opportunities and power have been distributed for centuries in a way that benefits people who are white and excludes people who are not. And this structural racism oftentimes works in tandem with homophobia, with transphobia, with sexism, and other forms of oppression. And it also contributes to and perpetuates economic inequality. And so poverty is often framed as an individual's personal failure rather than the structural one that it actually is. And so despite the clear evidence that shows that Black and Brown people are more likely to live in poverty than their white counterparts, members of the LGBTQ+ community are more likely to live in poverty than cis straight people. And both cis, Black, and Brown people and queer and trans Black and Brown people are more likely to be paid poverty level wages compared to their white counterparts. And so this racialization of poverty is the same reason that a majority of adults that are eligible for Medi-Cal come from communities of color. And all of these factors influence a person's health and well-being too, including their oral health and well-being. So systemic racism leads to Black, Latino, and Indigenous populations being forced to bear a disproportionate burden of oral health issues. They experience tooth decay, periodontal disease, and oral and pharyngeal cancer at higher rates compared to their other racial groups. The American Indian and Alaskan population suffers from tooth loss at incredibly high rates. And lastly, adults of color are less likely than white adults to report the condition of their teeth as good, very good, or excellent, as you can see in this graph here. And lastly, one of the most insidious ways that structural racism really impacts oral health is the belief or the false belief that communities of color don't care about their oral health. So you'll hear today from our partners about how this isn't a belief that's rooted in reality, and instead systemic issues, not individual decisions, are the driving factors for poor oral health outcomes of Black and Brown communities. And the only way that we can achieve true oral health equity is to hold our systems accountable and dismantle these systemic barriers that are engaging in structural racism. So a big goal of this report was to begin chipping away at those systemic barriers. So I will quickly walk us through the process of writing this report, and then we'll hear from our equity core group. So if you go to the next slide, please. Thank you. So this was written in partnership with 5 other organizations who you'll hear from shortly, and together we make up the equity core group. And so we first all met as a group for a grounding and envisioning session to really define the term oral health equity. And then we conducted one-on-one interviews with each member of our equity core group. And lastly, we did a collective feedback session. And I'll go into more details for each of these in the next slides. Next slide. And so the word equity has been used a lot, and it's become pretty ambiguous. Even though there is an actual definition, it's still used differently by different people. And you can't achieve oral health equity or written work towards oral health equity without first defining what it means. And so our first order of business as a group was to figure out what the term meant to us. And we did this by answering some of these questions that are on the slide here. So what's missing from the standard definitions of oral health equity? What does a society where everybody is well in terms of their oral health look like? And what are the ways in which our current systems are not achieving oral health equity? And what came out of this was that oral health equity should be racially equitable. It should be physically, culturally, linguistically, and financially accessible. It should be trans inclusive and gender expansive. And so our final definition of oral health equity was oral health equity is achieved when systemic barriers to quality oral health care are dismantled, resulting in the best possible oral health outcomes for all communities, regardless of their race, ethnicity, income, spoken language, gender identity, sexual orientation, age, immigration status, disability status, or zip code. I know that's a mouthful, but every word there is necessary. We can go to the next slide. So our next step was to do one-on-one interviews with our equity core group to really pinpoint the challenges that their specific communities had been facing, and to try to determine how to remedy those challenges. And so these are some of the questions we asked in our one-on-one discussions. And after these discussions, we really categorized the challenges and the work that our partners were doing to address those challenges into 4 overarching major themes. And then we worked through some potential solutions to the major themes that had been seen across all communities. And so these interviews are really essentially what helped us come up with our main sections of the report and the actual recommendations that are in the final report. Next slide. So lastly, we had a collective feedback session where we brought back the recommendations to the whole group and wanted to see if we had captured all of the community needs that had been discussed during our meetings. And so we asked these questions to our equity core group. And these questions in this session was really to check our own work to make sure we hadn't misinterpreted any of the challenges that the group had brought up, that their communities had been facing, and to make sure that we were writing about them and presenting them in a way that was accurate. Next slide. So I mentioned that our equity core group is comprised of CPEN and 5 other community-based organizations. So we are a small but mighty group. Our partner organizations represent the racial, ethnic, and regional diversity of California, and we very intentionally picked them due to the incredible work that they're doing to advance oral health equity in their own communities. And so I'm really excited for you all to hear from them today. We'll get started with some brief introductions. So I'll go ahead and pass it to Andrea Williams to introduce herself first.
Hi, everyone. My name is Andrea Williams. I'm the Executive Director of the Southside Coalition of Community Health Centers. Southside is a coalition of 8 federally qualified health centers that works together to to improve access to care in South Los Angeles.
Thank you, Andrea. I'll pass it to Dr. Thakur. Oh, Dr. Thakur. Thank you.
Hi, everyone, and thank you for being here. I am Yogita Thakur. I'm a pediatric dentist and a public health dentist by training. I am the Chief Dental Officer at Ravenswood Family Health Network. We're a federally qualified health center in the Bay Area in East Palo Alto, California. Thank you.
Thank you. And I'll hand it over to Sarait next.
Yes. Hello, everyone. This is Sarait Martinez. I'm the Executive Director with Centro Binacional para el Desarrollo Indígena Oaxaqueño. And we work with Indigenous farm worker communities in two major agricultural regions, the Central Valley and the north part of the Central Coast. And we have an office in Fresno, Madera, Greenfield, and Salinas in Monterey County. And thank you so much for having me here.
Thank you. I'll pass it to Gina next.
Hi, good afternoon, everyone. My name is Gina Trusenbot. I'm a Policy and Research Associate with SCOPE, Strategic Concepts in Organizing and Policy Education. And we're a grassroots base building organization on Tongva land and specifically in the area of South LA, focused on advancing social and economic justice through community organizing and leadership development of Black and Brown community members, engaging in strategic alliances and civic engagement, as well as policy advocacy. And our work around oral health is really through this lens of uplifting and centering community priorities and creating spaces for community members to shape the solutions of the identified issues. And so while we have been in the oral health space since 2018, we were initially asked to join the oral health efforts because there hasn't historically been a lot of grassroots voices shaping this space. And so we're really thankful to be here today with some of our friends here on the panel. And so just also want to mention that the way that we approach our work with our coalition partners is really through a systemic examination of the structural drivers of disparity that have impacted South LA, including gentrification and displacement, policing and suppression, environmental racism, and poverty, disinvestment, and joblessness. And I think this is important to note because when we're thinking about oral health, we're not just thinking about access, which includes many direct and more nuanced barriers, as many of you know, that are a result of structural racism, as Ruqayya mentioned in the beginning. But we're also really thinking of the economic outcomes for our community members and the ability for them to work in the oral health care sector. And so just wanna set that context as well.
Thank you so much for that context, Gina. And last but certainly not least, I'll pass it to Dr. Lei.
Hi, I'm Hun Lei. I am Chief Dental Officer at Asian Health Services, located in Oakland, California. And in the last, couple of years, we have been dealing a lot with the anti-Asian hate, incidents that you probably have heard about it. So I'm very happy to be part of this equity core group. And thank you so much for joining us today.
Thank you, Dr. Lei. If we can go to the next slide, please. So during the report writing process, I mentioned that we came up with 4 overarching themes after discussing community needs with all of our partners. And so these are the 4 themes that consistently came up and that each challenge fell under. And so we really wanted to emphasize that structural racism is at the core of our health delivery systems overall, and because of that is also a part of our oral health delivery systems. And to effectively dismantle that, we have to move beyond the individual, as I was talking about earlier. So individual education and action are not enough and will not address the deeply rooted issues that do exist. And so instead, we have to address these systemic barriers if we want true oral health equity. So the 4 major themes and issues were coverage barriers, cultural and linguistic access barriers, workforce barriers, and data barriers. And so we'll now hear from our speakers about our recommendations to begin addressing and dismantling these barriers. So I'll go ahead and pass it back to Andrea first to talk about some coverage barrier issues and solutions.
So the first systemic barrier that we discussed was coverage barriers. One of the most significant barriers to accessing oral health care for low-income communities of colors is the lack of stable, preventative, and restorative dental coverage for adults. You might have remember that Carolina mentioned earlier that coverage for dental services under Medi-Cal were changed at least 3 times over the last 15 years. They were either eliminated, partially restored, and then fully brought back. Currently, we currently have full coverage, but there's always the chance that due to budget cuts and things like that, dental coverage could be eliminated or certain dental procedures could be eliminated as coverage. These changes make it very difficult for patients to know when they can't get dental coverage. A lot of patients do not even know that when they have Medi-Cal, they also have coverage for dental services. And so one recommendation that we had was that the California and the federal government should work together to establish permanent full scope dental coverage for adults with Medi-Cal. By doing this, it would ensure that coverage would always exist and that losing dental coverage wouldn't be the first thing on the chopping block whenever budget cuts need to be made. There has to be a connection between primary care and oral health care. So the second recommendation is to integrate oral health care with primary health care and improve accountability so that we always know that those 2 services are together and that there is a connection between primary health care and oral health care, and that there should be some accountability in terms of making sure that people have that access and that there's a referral process to getting oral health care and making the connection that your oral health can directly affect your overall health. And so with this second recommendation to integrate oral health care and primary care, there's recommendations to do co-locations of services where you have primary care services and dental health services located in the same location or very close to each other. So having dentists and primary care providers in the same clinic, that way you can ensure that you can make that good handoff from the primary care provider to the dental provider to ensure appropriate dental services are received. Another recommendation is for to create medical dental referral and navigation services. There are some areas in the state where this exists, where primary care providers can make that warm handoff and refer to a dental provider, or making sure that primary care providers check and see that their patients have actually had dental oral health services within the last year. And another recommendation as well is to bring services directly into the community. In Los Angeles, the Los Angeles Unified School District has worked to bring oral health services on site at school campuses. So this alleviates parents having to take time off of work to take their kids to the dentist. They can get basic exams, sealants, teeth cleanings right at the school, and that helps working parents who often can't take time off of work to take their kids to dental appointments, and most dental offices are not open in the evening. So that also allows parents to have their child get the oral health that they need, or at least be alerted to issues. By having a checkup at the school, a parent can be alerted to more if their child needs more oral health needs and services.
Thank you so much for that, Andrea, for that overview and the examples of how to successfully integrate oral health care into primary health care. Something I also want to make sure everyone sees is this graph on the right. It compares the percentage of adults who have no natural teeth by dental insurance status. And based on this data, you're almost 3 times more likely to lose all of your natural teeth if you don't have dental insurance compared to those that do have dental insurance. So that's a huge disparity. And so even just establishing permanent dental coverage for adults would be a huge win. On the point of integration of oral health with primary health, I feel like ever since I've learned about that, I've noticed how so many of the issues we try to fix in the oral health delivery system are issues that can actually be addressed and even resolved if we were to integrate oral health and primary health. So thank you, Andrea, for sharing the examples of what that might look like and how it would improve the overall health of residents, especially in South LA. So now just expanding access isn't enough. We have to make sure that the coverage that folks are getting is sufficient and actually addresses the cultural and linguistic needs of patients. And so I will pass it to Dr. Thakur to talk about one of our recommendations in our cultural and linguistic access barriers section.
Thank you, Ruqayya. I think as we approach caring for our patients, speaking their language is very important, but I think also as important or maybe more important is understanding their point of view and their perception. And all of that could be, really put together under cultural and linguistic competency of a clinician. And some of those perspectives shape how we provide care, how they perceive the care, and how our patients actually follow up with our recommendations. We understand from our patients' point of view that if we're able to understand why they make certain decisions the way they do, I think it will also help us provide better care and be partners in care in improving our patients' overall health and oral health. So to that point, I feel like things that we discussed and recommend is that to approach care from trying to understand our patient's perspective and asking those questions, which kind of help us understand how we deliver care. As dentists, we often, advocate to our patients to reduce drinking juice. One of the things that we realized as part of some of the other work that we've been involved with was that the juice almost was like an affordable luxury and an alternative to the tap water where there were concerns about safety. So if that's the perspective that the patient is not using tap water, I think to encourage drinking tap water merely alone, not knowing the background, is not really helpful. And other things that, similarly that we've encountered is in our clinical practice, when we saw patients in clinic, we ask all the time what kind of toothpaste they use. And I hardly ever get a response that says anything other than a fluoridated toothpaste, yet they have disproportionate amount of caries. And, we had a unique insight into this that during telehealth visits during the pandemic, we would ask parents to show us the toothpaste, and they often brought about a toothpaste that had something written on it, which either was either it had the words fluoride free or it had the term fluoride. And because English is not their first language, a lot of them did not have could not tell us whether it was a toothpaste that had no fluoride or it had toothpaste that has fluoride, because they did see the term fluoride on the toothpaste, and that's what we were asking for. Do you know if the toothpaste has fluoride? And I think that was really valuable for us as we as we provide care, to know that if we're asking for things that may not line up with their understanding of English, we will not get answers that are really meaningful and that will help us provide care. To that, with that and several other experiences have shaped how we provide care and how we think care should be provided. And another example from Ravenswood that I would like to share is that we have a questionnaire for the families, and it was really created as an intake questionnaire for our special needs patients as a way to figure out how best we could serve them and what the provider needed to be able to see them in clinics. So to that, those are kind of our examples that we work that have shaped how we provide care in a cultural and linguistically acceptable way. Thank you.
Thank you so much, Dr. Thakur. I know I've told you this before, but you always have such great anecdotes to really demonstrate the need for cultural humility from our systems and our providers. And I think the sugary drink example for me was really important because I remember there was some research published a few years ago. Well, actually, there's a lot of research out there that demonstrates that marketers are targeting communities of color and communities with low incomes with ads for unhealthy products like junk food and sugary drinks. But I remember there was one in particular that stood out to me. It was a study in New York, I think, that found that the number of ads and sales for sugary beverages actually increased in poorer neighborhoods the first week or so after people got their monthly food stamps. And so these examples really kind of show how capitalism and racism are working hand in hand to contribute to oral health disparities and in turn, poor oral health outcomes for communities of color and low-income communities. So thank you again, Dr. Thakur. I will pass it to Sarait next to talk about our other cultural and linguistic access recommendations.
Thank you both for getting us here, and I think for highlighting that access is not enough to support the diverse communities of California when it comes to to just access to care. I think our communities have faced a lot of barriers, even from our towns of origin in our countries to coming here and having access to health, and especially dental health. So we know that at least for the communities that we work we're like culturally diverse. In Mexico alone, like there's 68 different indigenous language that our community, the Mexican community speaks. That does not encompass like all of the communities that speak another indigenous language that live in California. So with that said, there's a huge diversity in sometimes, the primary languages that clinics, doctors have access to is not enough to ensure that people are getting the right information to take care of themselves and to access the information. So for that reason, and just to put an example, before I go to the recommendation, is also like just in our communities working with Indigenous farm workers alone, we have just with the mixed Indigenous language, there's 81 different variations of that language. That means that they're unique languages that among each other are really hard to understand or sometimes impossible to understand what's happening. So it's important that, even within the Mexican community, it's not assumed that everyone speaks Spanish, in that we have proper interpretation. As an example, again, there's a diverse communities that we have, so we need to make sure that we are covering those languages. But some of the two of the recommendations that I want to talk to you about is really improve access to quality interpretation and translation services. A lot of the work that we've been doing just in regular access to health is like we get a lot of communities that come to our office asking to help us navigate just the health system in general, and that when they go to the doctor, they often, use their family members or their kids to translate. And we know that is one, not legally correct, but also not adequate for family members to be doing that. So we really want to see that there's not just access to interpretation, but quality translation, interpretation services. And also just to say that it's not so much about providing translations, because our languages are not written languages. We're developing that, but there's a lot that is not, because there's so many variations, there is not like standard way that everyone's gonna read that. And within our communities, because we have lack access to education, even in our towns of origin, many folks don't know how to read and write. So the best support is providing interpretation services, at least for Indigenous languages that we work with. And we also know that there's issues really when accessing medical interpretation service lines, because one, they often don't have the languages or the variation of the language that we're looking for. And it's because there's a lack of knowledge of our Indigenous languages when calling that. And we also have heard that, you know, people are getting up, like it's not efficient, and it doesn't support our communities. And when people don't get that support, like people really get disencouraged of continue accessing services, or even when they go in just to check in and sign up, like if they don't have a Spanish speaker that can help fill out papers, like people really get turned off, and like they just don't trust the person or feel like they're not welcome there. And something that we use to support community members access services and to have some tools so when they go and seek for that support, we have worked with, you know, our partner, California Rural Legal Assistance, to create the I Speak cards. And I think this is there's different versions of it. But what you can see in the screen is what we do within our organization, and specifically, you know, that we distribute to our community that know they speak primarily their language. And we use those cards to provide to community members and say, like, you know, when you go and access services, take your I Speak card, so then they know you don't have to communicate, but they can read it and they can seek that support. So that's one of the tools that we do and we encourage to do. And also, like, you know, making sure that there's a process, internal process also in the office to make sure that they're responsive to the I Speak card and they're able to recognize it, and that they know what to do when it's there. And it's stated within the protocols when people come into the office. Another thing too, at least for our community and for other communities, to really look for your community partners, you know, in your region, to see if someone, you know, can provide that interpretation system, especially for languages that are not, you know, like the common languages that people like interpreting services agencies provide. So I think it's important to have that on hand and to establish contracts. You know, a lot of the times we get calls to say, like, hey, can you help us with interpretation? And we help when the community is asking, when there's a need for it. And we are, you know, we would like to establish those contracts and to be compensated for that time, to be able to ensure that we have adequate interpretation and there's like a process and training for them. So that is one of the recommendations. And the other one that I think we have learned a lot through with COVID is that we really need to conduct effective outreach and education, and that community-based organizations that have worked on those, they have years of relationships with the community, are the trusted messengers, and should be also doing some of that work and supporting to ensure that people have access and knowledge how to navigate those services. So because they do it in an appropriate way. So a lot of the work that we do is, you know, we have people from those specific communities doing that outreach, because we know that they trust their communities, they know who they are, and that we're able to do it either, you know, with the flyer, but that flyer is just as a reminder. It's not like passing out a flyer. It's to really have those conversations and to create those materials that are easy to understand, that have less wording, and doing some of that. So really doing some of the outreach through community-based organizations, because they also know, or at least for us, we know where to go, we know where the events and the places where our community gathers, and we're able to do that effectively. So I think those are two more of the recommendations that we have in terms of how to work, at least with our communities, but I can, again, like I think they also work for diverse communities that may not have all of the access in their language when accessing dental health.
Thank you so much, Sarait. Ever since I heard of the I Speak cards that are on the screen that CBDIO uses, I think of them each time. I think of cultural and linguistic access, and I think they're such a great and easy way for people with limited English proficiency to request an interpreter. And something that I've actually been thinking about giving to some of my family members as well, because I think it could be really useful. And if there are any dental plans that are watching the webinar right now, you all know that state and federal law requires that anyone seeking dental care is provided with interpretation and translation services. And I think there were some really great gems in what Sarait was saying. You know, one way to improve access specifically for Indigenous communities is to contract organizations who are certified in interpretation services for these specific communities. And CBDIO provides medical interpretation and can and should be contracted with Medi-Cal to assist Indigenous callers who need interpretation during their appointment. So we can expand coverage and we can expand cultural and linguistic access, but we're also going to need providers to provide the services. So our next speaker, Gina, will talk about one of the workforce recommendations in our report.
Thanks, Ruqayya. So as was mentioned earlier, this core equity group is really bringing a racial justice community-based perspective to the workforce solutions. And so I'll share out two recommendations that we've highlighted in the report, and one workforce solution being community health workers. And so really dovetails off of what Sarait was saying around having trusted messengers and trusted people from the community who can really connect sort of that gap to care. And so community health workers are critical in providing services to low-income individuals and have the ability to reach Black, Indigenous, and people of color communities who face barriers in accessing quality healthcare and oral healthcare specifically as well. And I know there's a number of folks on this call who are in the work group to sort of advance the policy implementation. Community health workers typically come from the communities they serve, and so they know best how to bridge the gap in access to critical health services and resources. And so starting July 1st, 2022, Medi-Cal has expanded benefits to include community health workers or promotores services. And sort of one way to continue to advocate around the expansion of this is to advocate for the expansion of the types of billable services that community health workers can provide within Medi-Cal in the oral health space. And so there's a number of organizations, again, here today and not here today, who are leading this effort. And so I believe Andrea Mackey from CPEN can also maybe provide more information on how to get connected to this effort if you're interested in learning more or potentially helping to advocate to ensure community health workers can be integrated into our healthcare system. And so, yeah, some of the responsibilities that community health workers can provide include offering culturally appropriate health education and information, helping people get the care they need, and advocating for individuals and community health needs. And so I think it speaks a lot to what Sarait and Dr. Thakur have also mentioned in terms of bridging that cultural and linguistic gap as well. And so another workforce solution that we've explored and are recommending is dental therapists. So dental therapists, we're sort of looking at this from a two-pronged solution to both advancing oral health equity and economic justice. And so being able to increase access within the context of building trust through a community-centered approach. And in a survey that our grassroots oral health committee members, which comprises a lot of our member leaders, administered in South LA in 2022, so earlier this year, around half of residents didn't trust their provider. And for those who did trust their provider, we heard stories that it took them some sort of shopping around to find a provider who they felt like they could go to long-term and who they felt like were being transparent about the types of services that were really necessary and sort of the payment options as well. And the coverage, the Medi-Cal coverage. And so some shared finding a provider outside of South LA. And when you disaggregate the data by renters, over half don't trust their provider or haven't found a provider that they are able to go to regularly. And so when we talk about trust, it has a lot to do with understanding the cultural and language barriers, as was mentioned earlier, and really being able to trust someone who has had a similar experience and knowing the community that you're serving. And so we see ensuring that those from the community are prioritized to become dental therapists and provide that basic preventative care, as well as being able to provide some basic procedures to their community. Because when you trust your provider, you're more likely to talk to them about some of the barriers you face, as was mentioned earlier, and you're more likely to make sort of a plan for how to take care of your oral health over the long term. And so the other sort of driver that the dental therapists are getting at are being able to create pathways for those who haven't historically been left out of the oral health workforce. And so 90% of those that we surveyed in the survey indicated that they don't have a family member who works in oral health care currently. And so, and over half of those surveyed that indicated that the top barrier to getting a job in the oral health care field is that training and education is too expensive. So we know that there's more to be done to increase BIPOC communities as dental providers, including increasing incentives to, pursue a dental career pathway. But we also know that, we've been looking at this mid-level provider as a path for realistic educational attainment for community members, because it typically takes 2 to 3 years to be trained. And it's an opportunity for those who haven't been on an education trajectory recently and are grappling with systemic issues that make it challenging to really be integrated into this workforce. And so I'll also mention that for us as Scope, this is also about building power across our communities and showing up in solidarity. And we know that our partners in rural and urban American Indian communities have indicated that they have been wanting this for a long time. And so, and they see the benefit and want to be able to partner to really ensure that dental therapists can practice statewide. And so we also know we need community residents living in the community to be able to serve their community and have good paying career pathways. And as one of our community leaders, Patricia, has said, if we ourselves can become dental therapists and support our families and spend money at the small businesses in our communities, we're also supporting the economy of our neighborhood. And so this solution is not only about access, but in some ways is also about place-based investment. And so we've heard from different communities that the community wants, that the reality is people in urban cities are still not accessing the dental care they need. And we're not necessarily choosing, one solution over another, but we're saying we need multiple solutions to really get at this issue of access. And so where dental therapists are not replacing dentists, but they're a part of the dental team and really expanding the reach of the dental team. And so dental therapists aren't currently authorized to work in California. So our statewide coalition is exploring strategies to allow dental therapists to practice in the state, including looking at education models and other details, such as scope of practice, and other strategies to ensure their role in the dental team matches both the workforce and access needs of low-income communities of color. And so, so I think those are some of the recommendations that we have, and I'll pass it back to Ruqayya.
Thank you so much, Gina. Something I was thinking about while you were talking was how, obviously you said trust is such an important, if not the most important factor in a relationship between a patient and a provider. And I've seen personally, many instances in my own family of how the level of trust has automatically increased when providers come from my background. And so I'm privileged to be able to say that and experience that firsthand. I'm South Asian. There are a lot of South Asian providers out there. But unfortunately, people from other marginalized communities may not be able to have the same experience because they might not have ever been to a provider that looks like them or comes from their community. So hopefully this can help us begin to think about the importance of trust and how we can begin to work towards expanding the dental workforce and create more opportunities for members of historically marginalized communities. So thank you, Gina, especially for sharing those specific experiences of the community residents in South LA. And now I'll pass it to Dr. Lay to talk about how we can improve data collection and reporting in oral health.
Okay, well, this has been a very rich conversation. So thank you to all speakers and CPAN for bringing up these issues. And also thanks go to all the attendees for joining the call. So I'm going to close the webinar by talking about data. I love data. And my comments are intended to be thought-provoking. Okay, so I'm not going to give you the answers. I'm just going to talk about the issues that I see with the data that we have available at this time. We should keep in mind that we should design this research to allow us to collect meaningful data, because we all know data drives decision and policies. So the data is not only essential, but critical if we want to identify and close the healthcare gaps and inequities. Unfortunately, many resources have been dedicated into collecting data with such narrow focus that when it comes time to use the data to examine other related issues, the data may not be as useful. We as a healthcare system, in my opinion, are data rich, analysis poor. We have a lot of data, but we cannot tie them together to make the picture whole of what we try to paint, articulate, and use them to make changes. Also, if you look at most of the data available today, most are talking about utilization, how many receive care and cannot access to care, how many are edentulous, but no cause of tooth loss. Was it due to lack of care, which is the main assumption, of course, but could it be something else? Change in insurance status, medical conditions, race. An example is COVID effect on oral health status of our patients. Do we fully understand or know the consequences of delayed care in case of COVID? Yes, we do have some evidence, but we need to look closer. We talk about telehealth and how it has helped, but is that so? Is there a downside What is the downside? So maybe the question should be how it has not helped, and not so much of how it has helped. We need data also of where care is taking place, progress in areas where care is needed but has not improved in the last decades. I said this because telehealth has become a big part of care during COVID, but we don't talk much about the digital divide among our communities. Rural, urban, patients of color, immigrants with limited English proficiency, patients with low education, low socioeconomic status, lack of broadband width, lack of internet access, and so on. We mentioned workforce earlier. Does workforce have a role in access to care? Of course, but do we have data on lack of workforce, of how lack of workforce has affected access to care and outcomes? Do we have true and accurate data on how language access has impacted patient care and outcomes? Do we know which language or which small communities have the most limited access to our patients? We still need to work on those things. Have we looked at the strategies that have been put into access to care issues in the last decades? Have they really increased or improved care? Do we really know? I think the data show yes, but we need to really have more in-depth details to say which strategies work and which one have not worked. Some of these strategies that have been put in place, as I said, may not have resulted in the outcomes we hoped for. So should we change the strategies? So my recommendation is to review the data at hand, take a deeper dive into the strategies in place and see if any of them works. And if so, what and how has it worked? If not, let's see how we can improve the strategies or maybe come up with different ones, like different team members, different trainings, different scope of the existing dental team members. We can't expect a different outcome if we keep doing the same thing over and over. So I raise these questions for you all to ponder, and I don't have the answers, but we should keep in mind that data collection needs to be designed and collected for broader purposes and not with a single focus as we move forward into the future. This is where we can make a difference. So I think I'm going to end right there. And if you have any questions, we can talk about that. Thank you.
Thank you so much, Dr. Lay. You asked so many critical questions that we should all be thinking more deeply about when it comes to data and how it really ties into addressing the root of the issues. And addressing the root also happens to be our report title. So I'm looking at the time. I know we're coming to the end of the webinar. I wish we had some more time for questions. Maybe we can answer one question, I think more of a forward-looking question, so we can all leave everyone with something like an action item, I guess. So there's one question in the Q&A that says, how can we engage dental providers in this work, especially in the issue of cultural humility or just increasing their level of advocacy to improve oral health care? I know we have providers on this call that are doing the work, but how can we bring in other providers too? Is there anyone that would like to answer that question?
I can jump in if you want me to. But anyway, yes. So I think most of the doctors, most of the providers that are on this call are probably already doing these things. What we need to do is we really need to engage the communities of dental professionals, not just those that are on this call, but not just those who work in public health, but really the private dentists out there. I think that's where the work needs to be taking place. We alone cannot do it all. So that's what so if you know any private practitioners out there, engage them in the conversation. And basically let them know that there is this side of the community, of the patient population that you don't see, that really need your expertise. So please think about reaching out to them. And really, that's how we can start the conversation.
Thank you, Dr. Lay.
I'll just add one more comment there, and I would say work, dental schools, work with local dental schools and also our local dental societies. I think we have an opportunity where we've engaged and we have, Dr. Lay and I and some other clinics, have student rotations, resident rotations. So we do our part, but somehow we need to figure out other avenues for exposure.
Thank you for that. And I know we're at time. There were a lot of resources that were being shared in the chat, so we can follow up to make sure that those resources and a recording of this webinar gets to you all, as well as all of our contacts information so that we can connect with those in our communities and build relationships with those that are working on similar issues, and also to get some of your questions answered that maybe we weren't able to get to today. So I'm really grateful to our Equity Core group for all of their work and really grateful to all of you for joining today. Thank you, everyone. Take care.
Thank you. Take care.